not very different with respect to pertuzumab, addition of pertuzumab to chemo and trastuzumab. But when we look at the IDFS at 8 years in the intention to treatment arm, it was 2.6% benefit was there. But that was mainly driven by the node positive subgroup, around approximately 4.9, almost 5% benefit with respect to 8-year IDFS in node positive subgroup. So if we look at the NCCN guidelines again, for PT1C till PT3, there is a recommendation of chemotherapy plus trastuzumab plus pertuzumab, at least for PT2 to T3 group. They have added this in the 2025 update. So even if it is node negative, but we have a T2 or T3 disease, so NCCN says you should give pertuzumab. While for node positive, it is universally recommended. It's a category 1 indication of using dual anti-HER2 blockade with adjuvant chemotherapy. Again, now if we have given new adjuvant therapy, then and we also have achieved PATH CR, so most of the people would continue with trastuzumab alone. But they also, the NCCN again 2025 recommends that for node positive disease, pertuzumab should be used if you have a baseline node positive, and even if you achieve a PATH CR, then you should continue with dual anti-HER2 blockade for a total of 17 cycles. If it was node negative in the beginning, then pertuzumab is optional. Now again, new adjuvant pertuzumab. This was again a randomized phase 3 Peony trial. Tumor size more than 2 centimeter, HER2 positive, ECOG 0 to 1, randomized 2:1 to per2 plus trans2 plus docetaxel for 4 cycles versus trans2 plus docetaxel for 4 cycles, followed by surgery and 3 cycles of FEC, followed by maintenance per2 plus trans2 versus trans2 alone. So if we look at the Asian subgroup, which they have analyzed here, so PATH CR was around 40% in the per2 group versus 21.8, almost doubling of PATH CR. 5-year DFS again 86 versus 75. Locorenal recurrence after surgery 0.9 versus 6.4. Distant metastasis without CNS metastasis 5.9 versus 10.9. So continuing pertuzumab in adjuvant had benefits in this Asian subgroup of the phase 3 Peony trial. So then you have future landscape. Future landscape looks very bright with now we have, because the slides are slightly old, we have the Destiny Breast 11 study, which has shown that, and HER2 followed by PTH leads to better PATH CR rates compared to chemo followed by dose dense AC followed by PTH and neoadjuvant setting. Then again, this is TDM1 plus tucatinib trial, which is ongoing. So in metastatic setting, we have the landmark Cleopatra trial, trans2 plus dosi with or without pertuzumab and first line HER2 positive MBC. So we have a median PFS of 18.7 versus 12.4 and a landmark 8-year OS of 37% versus 23%. Landmark PFS, 8-year PFS of 16% versus 10%. So addition of pertuzumab definitely improves survival as well as PFS in first-line metastatic HER2 positive MBC breast cancer. So this is a treatment algorithm. If you see whether it is the relapse is within the first 12 months or at least more than 12 months after completing adjuvant chemotherapy, adjuvant therapy. So if it is more than 12 months, then you give 6 to 8 cycles of PTH followed by dual anti-HER2 blockade till progression. If it is less than 12 months, then you go for testing of, you have two options. Whether you see whether CNS metastasis is there, then you can try for tucatinib, capecitabine, and trastuzumab, followed by TDXT, or the other way around too is fine. But if there is no CNS metastasis or stable brain metastasis, then TDXT followed by tucatinib, capecitabine, and trastuzumab. And for third line, we have TDM1, and then you have other options like neratinib, capecitabine, lapatinib, trastuzumab, lapatinib, capecitabine, margetuximab chemotherapy, and trastuzumab chemotherapy. So then again, we have a trial of trans2 plus per2 plus eribulin in first line HER2 positive MBC in treatment naive disease with at least 6 months since prior neoadjuvant or adjuvant cytotoxic chemotherapy. Eribulin 1.4 milligram per meter square day 1, day 8 plus P plus H versus DOSI or PACLI plus P plus H. Primary endpoint was PFS, secondary endpoints for ORR, DOR, OS, quality of life, and new metastasis free survival. So we look at the PFS was numerically better, eribulin group 14 versus 12.9, hazard ratio 0.95, but the confidence interval it is crossing the unity. OS not significant, although numerically not reached versus 65.3 months. Then I think this trial has shown its results in a press release in around 2 months back, and we also had ASCO presentation about this trial, that is the Destiny Breast 09. First line trastuzumab deruxtecan plus pertuzumab versus the PTH group, PTH arm. So it has shown improved PFS and response rates in the first line. So India is now privileged to have its first pertuzumab biosimilar. So this is the trial which was a study which was published in last year, March 2024, a randomized double-blind phase 3 study in India to evaluate efficacy, safety, pharmacokinetics, and immunogenicity of pertuzumab biosimilar in comparison with Perjeta in patient with HER2 positive MBC. It was a randomized double-blind multicentric trial which showed that it is bioequivalent to the innovator molecule. So what to conclude from all these data? Access to anti-HER2 agents is increasing. Eligible patients should be brought under the neoadjuvant first approach. De-escalation strategies are being explored extensively, and that will be part of personalization in coming time. So positive long-term data of pertuzumab in upfront adjuvant setting should be considered for node-positive patient particularly. And new data may add some confidence in adding pertuzumab in neoadjuvant and adjuvant as continuation. Trans2 pertutaxane is the undisputed standard of care in HER2 positive MBC first line till the Destiny Breast 09 data comes out fully and it is approved by the FDA. And there are various trials which are ongoing and may pay for newer strategies in future. Thank you, and over to the organizers.
Thank you, Dr. Priyanshu, for the wonderful presentation. How are you? Do you continuing the dual anti-HER2 in node positive patients after PCR?
Yeah, I think there is some subgroup analysis also in higher T stage, especially T4 if we have, and node positive, I'm continuing.
Not in all patients.
Node negative, I'm not.
No,
I
no.
give them the option. I
Like
give them
T2
the
and 1.
options.
Given the option, you will like to, if no financial
It's
constraint.
better safe than sorry, I think. I mean, if it relapses again, you are using pertuzumab only. So, I mean, on node positive, definitely I would like to give. And if there are some, if you have probably a LABC with T4 disease or T4B disease, so definitely I would like to use.
Thank you. Thank you, Dr. Priyanshu.
Thank you, sir.
Yeah, with this, I think we come to the end of the day one of our 2-day CME. I thank all the speakers, panelists, and all the faculty who have participated actively. And we will see you tomorrow at sharp 7 p.m. for the second day of the conference. Tomorrow we will focus on the GI, genitourinary, and the hematology systems. Thank you,
Thank you,
everyone.
sir. Thank you. So thank you everyone for joining, and thanks to all the faculty and the former colleagues, supporters. Thanks to my colleague Dhruv and Swarangi. Good night, everyone. We'll join tomorrow at the same time. Till then, good night.
Thank you.
Thank you,
Bye.
sir. Thank you, sir. Support team.